Picture this. You wake up one morning with that familiar heaviness low in your abdomen. You head to the bathroom, sit down, and wait. Nothing. You try again an hour later. Still nothing. By the third attempt, something has shifted. Now there is real discomfort. A dull, deep ache radiating from your lower back down into your pelvis. You feel bloated, full, and somewhere in the back of your mind, a quiet voice starts saying something is wrong. If that scenario sounds familiar, stay with me through this entire video, because what I am about to explain could protect you from something that starts as discomfort and ends as a genuine medical emergency if it is not understood and addressed correctly. I am Dr. Richard Hale, and today we are having the conversation that most appointments never get to. Why does this happen, especially after 60? What are the warning signs that most people completely misread? What do you do right now, tonight, if this is happening to you? And what do you change going forward so it does not keep coming back? By the time we finish, you are going to understand your own digestive system in a way that changes how you manage this for the rest of your life. Before I explain what is happening, I want to start with something important that most people get completely wrong. They treat this as a minor inconvenience, a few uncomfortable days that will sort themselves out. And the reason that framing is dangerous is that the condition we are discussing does not stay minor if it is left unaddressed. Understanding exactly what is happening inside your body is the first step toward addressing it correctly. The medical term for what I am describing is fecal impaction, but set the clinical language aside for a moment. Here is what is actually happening in plain terms. Your large intestine has one primary function. It extracts water from whatever passes through it. It is extraordinarily efficient at this. The problem begins when stool sits inside the colon longer than it should without moving forward. Your intestine does not know to stop pulling moisture out. It simply keeps doing its job. What starts as soft, manageable waste gradually becomes harder, drier, more compact. Over days, it can transform into a mass with the density and texture of hardened clay. Here is the detail that catches most people completely off guard. This almost never happens suddenly. It builds over 3, 4, sometimes 7 or 8 days. During most of that time, you may feel only mildly uncomfortable. You might still be going to the bathroom every day, but each time you are only passing a fraction of what your body needs to eliminate. A little gets through. A significant portion stays behind. The next day, the same thing. The day after that, the same thing again. Think of it this way. Imagine trying to push a large, rough, irregularly shaped stone through a garden hose. That stone is not going to slide. It is not going to compress, and the harder you push from behind, the more it wedges itself in. That is the exact mechanical situation in your lower digestive tract. And the harder you strain and push on the toilet, the more you are compressing that mass further rather than moving it. If you find this kind of clear, detailed explanation useful, subscribe to this channel. This is exactly what I make every week for adults over 60 who want honest, evidence-based health information. Now, let me explain why this happens more after 60 than at any other point in life. Why this becomes dramatically more likely after 60. After 60, several physiological changes happen simultaneously that create what I would describe as a perfect storm for this condition. Understanding these changes is not about accepting decline. It is about knowing what you are working with so you can protect yourself effectively. First, intestinal muscle contractions naturally slow with age. The rhythmic wave-like movements that push waste through your digestive tract, called peristalsis, become less frequent and less forceful. Transit time through the colon increases. The longer waste sits, the more water is extracted from it. Second, pain perception in the gut becomes less reliable. The signals that would prompt a younger person to recognize and respond to rectal pressure may arrive late, arrive weakly, or not arrive at all. You may not feel the urgency that would otherwise prompt timely action. Third, many adults over 60 take medications that significantly slow gut motility. Blood pressure medications, particularly calcium channel blockers, opioid pain relievers, iron supplements, calcium supplements at high doses, antidepressants, antihistamines, diuretics. Any of these can contribute meaningfully to the slowing of your digestive system without ever appearing on a warning label you would connect to this problem. Fourth, the natural thirst reflex diminishes with age. You may feel completely comfortable and register no sense of thirst, while your body is chronically dehydrated at a cellular level. Your large intestine extracts water from whatever is available. If there is not enough water coming in, the waste stream becomes progressively drier. None of this is your fault. It is a combination of biological changes that compounds quietly over time, and that most people have never been clearly told about. 4 symptoms that are almost always misread. This is the section I most want you to pay attention to, because getting these symptoms wrong leads to taking exactly the wrong action, which can make the situation significantly worse. The first misleading symptom is watery liquid discharge. This one sends more people in the wrong direction than any other. You may be sitting there thinking, I am not constipated at all. I actually have diarrhea. Here is what is actually happening. When a solid, hardened mass blocks the lower rectal passage, the newer, looser waste coming down from higher in the colon has nowhere to go, so it does the only thing it can. It seeps around the edges of the blockage and leaks out as watery liquid. This is called overflow diarrhea, and it is one of the most dangerous diagnostic traps in digestive health. The danger is that people reach for anti-diarrheal medication, and those medications, the kind that stop intestinal movement, are absolutely the worst thing you can take in this situation. They do not just stop the liquid output, they slow the entire digestive system, allowing the blockage to continue hardening and growing. If you have watery discharge alongside a heavy, aching sensation of rectal fullness, do not touch anti-diarrheal medication. The second misleading symptom is urinary difficulty. You may find yourself suddenly struggling to urinate. You feel the urge, you go to the bathroom, but only a trickle comes out. Or you need to go every few minutes and produce almost nothing each time. This is not coincidence, and it is not a separate problem. Your rectum and bladder share a confined pelvic space. When the rectum is distended with a large, hardened mass, it physically compresses the bladder from behind, partially obstructing normal urination. In severe cases, this urinary retention becomes a medical emergency in its own right. The third misleading symptom is lower back pain, a deep, non-specific ache in the lumbar region that has no obvious connection to your bowel. Most people attribute this to a pulled muscle, arthritis flaring up, or simply the discomforts of aging. But when rectal pressure builds to a significant level, the pain radiates outward into the lower back, the thighs, and the hips. If you are experiencing unexplained lower back discomfort alongside any bowel irregularity, that combination is a signal worth taking seriously. The fourth symptom, particularly relevant for older adults, is sudden cognitive change, disorientation, mild confusion, unusual agitation that has no obvious cause. Research has documented that significant bowel obstruction can contribute to what looks like a cognitive episode in older adults. This is due to the systemic physical stress the body is under, combined in some cases with early toxic buildup from prolonged waste retention. If an older person in your care seems suddenly confused or unlike themselves without an obvious explanation, consider their bowel status as a contributing factor. What can go wrong if this is not addressed? I want to be direct about this because you deserve to understand the full picture, not a softened version of it. A fecal impaction is not a discomfort to wait out. Left unaddressed, the consequences escalate in a predictable pattern. In the first stage, the intestinal wall, which is living muscular tissue, becomes severely stretched beyond its functional capacity. Blood supply to that stretched tissue begins to diminish. The muscle begins to lose its ability to contract. That section of bowel goes quiet. In the second stage, the distension spreads upward, affecting higher sections of the colon. Nausea and vomiting begin. Abdominal distension becomes visible. The person looks and feels genuinely unwell. In the third stage, the intestinal wall reaches its physical limits. When those limits are exceeded, the wall can tear. When that happens, the contents of the bowel enter the sterile abdominal cavity. What follows is a rapidly progressing infection called peritonitis. Without emergency surgical intervention, it is life-threatening. The window between serious but manageable and genuine emergency is narrower than most people assume. Knowing the signals that require immediate action is essential. Go to an emergency room immediately if you experience a rigid, board-like abdomen that is tender to the touch, a fever above 101 degrees Fahrenheit, sudden severe abdominal pain that is constant and worsening rather than crampy and intermittent, complete inability to pass gas at all, vomiting that does not stop, or any sudden drop in blood pressure accompanied by confusion and cold, clammy skin. These are not wait-and-see symptoms. What to do tonight, the step-by-step protocol. Knowledge without action does not help you. Here is a clear, logical sequence to follow. The first and most important step is to stop straining immediately. Every time you bear down hard with a solid blockage in place, you are not helping. You are increasing intra-abdominal pressure, irritating already inflamed tissue, and risking additional problems. Straining will not dislodge a hardened mass. It has never worked. We are going to stop doing that right now. Step 1 is lubrication and softening with glycerin suppositories. These are available over the counter at any pharmacy without a prescription. Here is the information most people never receive. For a significant impaction in an adult, a single suppository is rarely sufficient. The appropriate approach for a hardened rectal blockage involves using 2 to 3 suppositories simultaneously. One alone may not generate enough lubricant to coat and begin softening a large dehydrated mass. Here is exactly how to do this. Do not stand or sit. Lie on your left side. This position, called the left lateral decubitus position, aligns the lower colon and rectum in a way that allows gravity to assist rather than work against you. Apply a generous coating of water-based lubricant to each suppository before insertion. The tissue is already irritated, and dryness at this stage makes everything more uncomfortable and less effective. Insert all suppositories as deeply as possible, positioning them alongside or against the hardened mass rather than near the entrance where they will simply slide out. Then lie still. You must hold this position for a minimum of 30 minutes, ideally 45. The glycerin needs time to melt at body temperature, disperse, and begin penetrating the outer surface of the mass. If you jump up and go to the bathroom after 5 minutes, nothing will have changed. After 30 to 45 minutes, rise slowly and go to the bathroom without forcing anything. If there is movement, allow it to happen at its own pace. If there is not, stay calm. Step 2 is rest, gentle movement, and repetition. If the first round produces no movement, give your body a full hour of rest. Get up and walk gently around your home. Drink a full glass of warm water. Warmth helps relax the intestinal muscle. Then lie down again and repeat the suppository process exactly as before. A second round frequently accomplishes what the first prepared. The first application typically softens the outer layer. The second reaches the core. Step 3 is knowing when to go to urgent care or the emergency room. If you have completed 2 full rounds of this protocol with appropriate waiting time and there is still no movement, or if any of the emergency symptoms I described are present, go. Do not continue managing this at home. Medical teams have access to clinical-grade enemas that reach further into the colon, imaging tools to assess the extent of the blockage, and in cases where all other interventions fail, a procedure called manual disimpaction that is performed with appropriate sedation. These are safe, well-established clinical interventions. Going to seek help is the correct decision, not a failure. How to protect yourself going forward? Addressing the current blockage is essential, but if nothing changes, this will return. Here is what the evidence supports for long-term prevention, particularly after 60. Hydration is the foundation. Water is the single most important variable in preventing stool hardening. The practical guidance is not to wait until you feel thirsty, because the thirst reflex genuinely weakens with age, and you may be chronically dehydrated without any subjective sense of thirst. 6 to 8 glasses of water distributed throughout the day. A full glass first thing in the morning, before eating or drinking anything else, which stimulates the gastrocolic reflex, a natural wave of intestinal movement triggered by fluid entering an empty stomach. Daily movement matters more than most people realize. Physical activity of your body directly stimulates the intestinal muscle contractions that move waste forward. A 20 to 30-minute walk after meals, even a gentle pace, has been documented to significantly accelerate intestinal transit time. For adults with mobility limitations, even gentle chair exercises, torso rotation movements, or basic stretching maintains intestinal muscle activity in a way that prolonged sitting does not. Review your medications with your physician. A wide range of commonly prescribed medications can significantly slow gut motility. Opioid pain relievers, calcium channel blockers, iron supplements, high-dose calcium, antidepressants, diuretics, antihistamines. This does not mean stopping your medications. It means raising the question directly with your doctor. Ask specifically whether any of your current medications may be contributing to constipation, and whether there are alternatives with less impact on digestive function. Many physicians do not raise this unless the patient asks directly. Be careful with stimulant laxatives. When stimulant laxatives become a daily habit rather than an occasional intervention, the intestinal muscle begins to depend on the external chemical signal to initiate movement. Without the laxative, it no longer contracts reliably. This is called laxative dependency, and it is more common in older adults than most people realize. If you have been using stimulant laxatives daily for more than 2 to 3 weeks, speak with your physician before stopping abruptly. Establish a consistent bathroom routine. Your digestive system follows circadian rhythms, and the gastrocolic reflex is strongest in the morning, particularly within 30 minutes of waking and within 30 minutes of eating breakfast. Use that window every day. Go to the bathroom at the same time each morning, whether you feel a strong urge or not. Sit, relax, and give your body 5 to 10 minutes. Over 1 to 3 weeks of consistency, your body begins to synchronize with this routine. And finally, posture matters. The human body was not designed anatomically to defecate from a standard seated toilet position with thighs at a 90-degree angle to the floor. A squatted position, with thighs angled upward, fully relaxes a muscle called the puborectalis, which otherwise creates a natural kink in the rectum. A simple footstool under your feet when you sit on the toilet, raising your knees above hip level, can meaningfully improve the mechanics of evacuation. For many people, particularly those with weakened pelvic floor muscles, this single adjustment produces a more significant improvement than anything else they have tried. Let me bring this together. What you have heard today is not complicated once you understand the underlying biology. The digestive system after 60 operates differently than it did at 40. It needs more water, more consistent movement, more awareness of how medications affect it, and more consistent daily routines to support it. When those needs are not met, what begins as minor sluggishness can build gradually into something much more serious. You now understand what fecal impaction actually is and why it is more likely after 60. You know the 4 symptoms that are most commonly misread. You know the emergency signals that require immediate medical attention. You have a step-by-step protocol to follow tonight if this is happening to you, and you have the long-term prevention framework that addresses the actual causes rather than just managing symptoms. If you are watching this for yourself, I hope this gives you what you need to take action tonight and to have a more informed conversation with your physician at your next appointment. If you are watching this for an older person in your care, do not wait for the situation to escalate before acting. A simple abdominal X-ray can confirm the presence and extent of a fecal impaction within minutes. The conversation may feel awkward. The consequences of silence are far worse. Everything in this video is for educational purposes only and is not a substitute for professional medical advice. If you are experiencing symptoms described here, please contact a healthcare professional. This information gives you context for that conversation, not a replacement for it. If this video gave you something useful, subscribe to this channel and share it with someone over 60 in your life who deals with this. Leave a comment below telling me how many of these warning signs you had heard about before today. I read every comment. I will see you in the next one.